Next speakers.
Thank you, Professor Play. Thank you for the introduction and thank you for the nice invitation. My name is Maximilian Hochmeier. I'm coming from Vienna and we are a lung cancer center where we are diagnosing about 800 new diagnosed patients per year. And I'm just treating lung cancer in our center. And I'm happy to share with you our experience with lung cancer and NTRK positive patients. These are my disclosures. I'm joined by Professor Wehner, and I'll let him introduce by himself.
Thank you very much. So, as said, my name is Gilad Weiner. I'm a pathologist from the Hadassah Medical Center at Jerusalem, Israel. I'm a molecular pathologist and a thoracic pathologist, and this is my disclosure. Thank you very much.
I want to show you one case initially and discuss all those different factors in treating patients with NTRK positiveness. My patient was at this time 30 years old, never smoker, presented with dyspnea and pleural effusion in another hospital. She had 3 bone metastases and we were diagnosed in March 2017 in another center, lung cancer in a right-sided located. At this time, we just performed ALK, ROS1, and PD-L1 staining and EGFR testing. We did not measure at this time NTRK or other biomarkers. NGS was also not routine performed at this time. So in the other hospital, the patient received 4 cycles of chemotherapy, cisplatin, pemetrexed, and for 1 year, pemetrexed maintenance. In August 2018, it was discontinued on the request of the patient. In January 2019, she showed the progress and immunotherapy was recommended to the patient. The patient had a pre-existing ectopic eczema and said she wants to think about receiving immunotherapy or perhaps docetaxel nintedanib at this time, and she was showing up in our hospital. When I saw the patient the first time, I said, we need new material. At 2017, the material was already old, not sufficient material there to analyze it. So we said we need from the pleural effusion more material, and so we performed a VATS. Initially, we also did a bronchoscopy, but we didn't receive enough material. We performed initially the first time an immunohistochemical staining at this time. It was already March 2019 or April 2019, and my pathologist performed the second time in her life an immunohistochemical staining. And the first or second test was already positive. And she said, this is impossible that the first test is already positive. And she was asking for a second opinion. And I was happy to receive the result and was contacting the company Bayer if we can receive larotrectinib for this NTRK fusion positive patient. They told me immunohistochemical staining is not enough. We have to perform another test like Foundation 1 or NGS or other tests if this is possible. At this time, we received Foundation 1 liquid, a test for free, but I had 2 tests, and we received this result from Foundation 1 liquid at this time that no mutation or alteration or some fusion was found in the liquid biopsy by Foundation 1. We also performed tissue liquid biopsy, but RNA testing was not performed at this time. So it was negative at this time. And now I want to hand out to Professor Wehner to comment that, because I'm not a pathologist, I'm a clinician, and I was so happy to have this immunohistochemical positive staining, and I had to organize this test. Foundation 1 tissue was negative because they just tested DNA and not RNA at this time, and I had to discuss it with my pathologist, which test would be then recommended.
So thank you very much, Dr. Hochmeier. So what drove the decision to test the NTRK in this patient? It's the recommendation, right? Today we screen all the advanced solid tumor for NTRK, And because non-small cell lung cancer is considered to be a low rate malignancy with low amount of translocation, this is why your pathologist, rightfully so, started with the IHC for pan-NTRK. And when she found out that it's positive, she requested a confirmation.
For us, it was really strange because we started at this time to test every patient, but the second test or first test was positive, and it was really strange for us.
Yeah, beginner's luck. Indeed.
Would you have a different strategy for screening your patients now as compared to 2019?
So now, since April, that was the strategy when we now test each patient. So each patient who has non-small cell lung cancer, excepting squamous cell carcinoma, each patient gets tested for NTRK with the antibody, and each patient who is not showing EGFR, ALK, or ROS1, any positiveness is receiving an NGS automatically also. Sorry, I forgot BRAF and NTRK, but when these 5 markers are negative, automatically NGS is performed immediately. But this is the strategy since 2019, April 2019.
Yeah, so for us, it's a little bit different. So from 2020, we started to screen all of our non-small cell lung cancer, adeno or squamous alike, for a very comprehensive genomic profiling. That was not the case in 2017. In 2017, we still were testing specific genes, and I mean, it was EGFR up front, and ALK and ROS and BRAF and KRAS, and of course the PD-L1. However, in 2020, we started to screen upfront before any therapy for 500 genes and translocation in the RNA level. So things have changed.
Our strategy in this situation is that we sometimes need to treat the patient very fast. So we are testing therefore EGFR and ALK and NTRK and PD-L1 upfront. This takes 2 or 3 days. And when there's nothing coming up, then we go for the NGS still, because NGS still takes, let's say, 7, 8 working days. And in some patients, we have to react very fast. And this is the reason why we still keep on sequential testing. Sometimes when the pathologist sees already initially that there's not enough material there, he does not perform this sequential testing. He went automatically for NGS, but also here NTRK and all other biomarkers are tested immediately.
Dr. Weiner, what would be the best practice for using molecular or histology, immunohistochemistry diagnostic tests for NTRK?
So I'm very glad you asked. So today we know that the ESMO, the ASCO, and other consensus actually recommend testing NTRK gene fusion in all advanced, unresected, or metastatic solid tumors. And the ESMO and the NCCN guidelines refer to NTRK gene fusion in non-small cell lung cancer as well. Another thing we need to remember is that NTRK gene fusions are typically mutually exclusive from other driver mutation. So you will not find the NTRK fusion with EGFR or other activating translocation as ALK. Another thing we need to remember that today we have a very good screening tool. We have a pan-NTRK IHC that can be used to screen the patient and very fast to find those patients that show positivity, that show expression of TRK in the tumor cells. And we will see it in the one of the next cases. However, we need to remember that positive IHC, immunohistochemistry test, requires molecular confirmation. And this molecular confirmation can be done using several techniques. However, NGS today is the preferred one. So basically, when you read the guidelines, you can see that we divide the tumors into basically 2 big categories. I will start with the rare cancer types with high prevalence of NTRK gene fusions, as secretory breast carcinomas, infantile fibrosarcomas, and cellular mesoplastic nephromas. Here, the FISH or NGS for the confirmation is actually more appropriate because of the higher prevalence. When we go to the other group, the second group, which is the common tumor, where the prevalence of NTRK gene fusion is lower, here it's preferable that we will start with pan-TRK IHC. And again, as I said, if positive, then you can confirm it by NGS or other methods. So this is one example of this algorithm. And actually, this is the algorithm suggested by the ESMO last year. So, and this is how we report the TRK IHC results. We can see a negative report and a positive report, but we need to remember that at least in my institute, when we issue a positive report, we reflex immediately. We order the confirmatory result, and we do not wait for the oncologist to refer to this additional testing. Another thing we need to remember is specifically about this case. Here, it's a case about a young, never smoker, female with adenocarcinoma of lung origin. This appeared to be a very distinct, separate biological group. The chances here of finding actionable mutations are very, very high. And I mean activating mutations as in EGFR or BRAF, or various translocations as ALK, ROS, NTRK, and RET. So at my institution, we will do for those, actually today it's for all, but years ago, we used to do, especially for this type of group, a comprehensive genomic profiling of about 500 genes plus RNA sequencing for genes fusion. However, I have to say, and maybe it's a little bit, we are a little bit cautious here at the Hadassah Medical Center. If the NGS will be negative, we will continue and do IHC for ALK, ROS, and NTRK, because we know that there are very rare cases of, let's say, ALK fusion that was not detected by the comprehensive genomic profiling. So just to be sure, and because it's a very small group, we'll continue and do another one if it's negative.
Thank you very much, Dr. Weiner. And it's interesting to observe that, again, different strategies are being used to identify NTRK fusion genes in the different institutions. I mean, I have a broader question, which is basically the following: using a panel of tests with NGS to identify a variety of different genes which may be mutated in non-small cell lung cancer. How do you look at the biomarker test report that come back from the pathology? Actually, do you take into account each individual gene which may be mutated, including additional genes mutated in patients with fusions involving NTRK? How are you processing that?
So in our center, we have a very good communication to our pathologists. We have at the moment 5 pathologists in our center. It's very easy to come in contact with them. If there is a problem in the report, I will call them and I will ask them, how can I interpret that? The NTRK immunohistochemical staining is actually very easy. It's positive or negative. And I know when it's positive, it's something not very often happening. So I can remember 3 positive results. I call my pathologist immediately, or sometimes she's calling me already before that. She's telling me NTRK positive. We can help the patient really very good in this situation. So this was also with this case, the patient was the immunohistochemical staining was positive, and she was calling me immediately that I can react in this situation on the result. And then we are waiting for a colleague from the university clinic was then doing a FISH analysis, and I was calling him every 3rd or 2nd day to ask if the result is already here, because I want to start the treatment in a high symptomatic patient, like in this case. But normally, I think it's a rare disease. We wait now. I think NGS is enough. like we saw before by Professor Weiner. And I think when it's positive, we're waiting for NGS. And I will call in this situation the pathologist to share our, let's say, not happiness would be the wrong word, because it's still a horrible disease. But in this situation, it's a good target that we can attack in this situation. And I would talk with my pathologist immediately in this situation.
All right, thank you very much. It's interesting to compare the strategies in different large centers on this frequent disease, which is not non-small cell lung cancer. Dr. Hockmeyer, can you share with us what happened to your patients afterwards?
Absolutely, I'm willing. So you can see here the development of the patient. I got a very good support of the Austrian Bayer company in this situation. I was calling the pathologist, said in 2 tests, NTRK was positive. So it was the FISH test. Normally now we would do NGS, and the antibody was positive. And so we organized very rapidly lautractinib. At this time, it was not labeled. So we received it at this time by the company. The patient received the first time on the 2nd of May 2019, the first time lautractinib 100 milligram twice daily. And because it was the first time and the patient was very young, was suffering horrible before on the disease. She was in a performance status 2, really in a bad condition, suffering horrible by the disease. And we were talking about dying already in this situation. And she received a medication. I talked with her. My experience in this drug is small, so I just can read it out of the publications. And she started, and 3 days later, I was calling her, and she told me, and this is looks like a dream. She told me that she's thinking about going out with her children and taking a bike tour. She's not in the best shape, but she can think to do it with her small children at the moment. And when she came up the first time in our clinic, 3 weeks later, you can see the remission, the partial remission in the X-ray. You see the baseline X-ray, and like you can see on the red star, the development is amazing. So you had, after a short time, a clinical complete remission after some days. And in the X-ray, we saw after 3 weeks, a perfect development in the situation with a clear partial response. And we are treating a lot of patients with EGFR mutations, ALK translocations, but such a fast remission I did not see a lot of times in my life. And I can say I never saw something like that. So after 6 weeks, normally we would not perform a PET-CT because it's such a rare disease. Even in stage 4, we wanted to document it in a perfect way to share this experience in this situation. And you can see here, development on the left side, you see A at the time of the initial diagnosis, before we started with lautractinib, and 6 weeks later, you see there was only a very small uptake in the bone lesion in the pelvis, but the rest was, there was no activity anymore. Also in CT scan number C, you can see here a huge pleural effusion. Patient was suffering of the pleural effusion, horrible. Even she had a drainage there. She could not breathe anymore accordingly. And then you see after 6 weeks, from my point, a clinical complete remission based on the RECIST criteria. We saw a partial remission, but this is a very high partial remission. Here is the development of the patient, and still since May 2019, she's taking the medication. What is really unbelievable good, I don't see her based on the symptoms. I just have to describe her routinely the medication, and she is living a completely normal life with no side effects on the drug. It's really amazing. And you can see here, based on the images, I got the approval by the patient to show which normal life she's living now. It's really amazing and motivating for everybody to share this case, to measure it. You don't see it that often, so we measured in about, now for 1.5 years, about more than 1,500 patients, or nearly 2,000 patients. And we saw it in the moment 3 times positiveness. And this is, when you find it, you can really treat the patient excellent, and the patient is now living a completely normal life, and it makes the patient happy, and it makes you, as a medical doctor, it's really that what you're searching for as an oncologist. So I clearly recommend to test everybody. Here the data based on the larotrectinib data in lung cancer, 12 patients were included in the trial, already presented by Professor Bley. You can see 12 patients had an NTRK fusion in lung cancer of this trial that was leading to the label. You can see here there were included male patients, female patients, also patients that were smoking, non-smokers, all these things. Also patients had brain metastasis, half of the patients had brain metastasis, half did not. The NTRK fusion included was 1 and the type 3. And you can see here that the remission in these patients was really good. 1 patient had a complete remission, 8 had a partial remission, 3 had a stable disease. You can see clearly on the waterfall plot that nearly each patient had a clear efficacy of the drug in this situation. And what is also very important, the data are so new and the median follow-up time is 12.8 months. Those patients are still ongoing. Like my patient, after 18 months or more, the patient is still ongoing and is doing a really, 15 months, is still doing, has a clear remission in the situation. And from my gut feeling, I think it will stay longer. And here we see median treatment duration was 9.2 months, but a lot of patients are still ongoing in this situation. Like before reported, from those 260 patients, 60 patients we see side effects, but when you want to focus on grade 3, grade 4 side effects, these side effects are not in a higher range. They are mainly based on grade 1 and 2, and these are general side effects, like and are not really relevant side effects. The patients are, some are pre-treated, where we know some side effects can, and it's very hard to document it, but some side effects can also can come from the oncological disease. So from my perspective and from my clinical impact, I would say in my patient, there was no really side effects based on larotrectinib in this situation. So this drug, my experience in this patient was clearly, is really fulfilling all criteria of a targeted treatment. The targeted treatment is leading to a very good remission and showing no side effect in this situation. I hand over now to the chairman to discuss these different questions.
Thank you very much, Dr. Ackmeyer. This is a very impressive observation, and the data you have gathered on non-small cell lung cancer clearly show the activity of this class of agents on advanced non-small cell lung cancer with fusion genes involving NTRK. Now it comes to a situation where we have to define what would be the general strategy to manage these patients with fusion genes involving NTRK, given the activity of this class of agents in this tumor type. So what advice would you give to the healthcare professionals who are currently managing patients with advanced non-small cell lung cancer? Do you recommend to test early? You mentioned that already, but at which stage would you introduce larotrectinib in your next patient, for instance?
So from what I learned, that we have to test each patient, even it's a rare disease, we really have to test every patient, because we cannot see any clinical criteria where we can see in the patient, this patient could be positive. So we really have to ask each patient, we have to ask for each patient, the pathologist, if there's no reflex testing, please test each patient. From my perspective, based on this case and based on the literature, what we saw, how larotrectinib works, I would clearly see larotrectinib in first line, the remission rates, the tolerability.
Thank you very much, Dr. Altmaier. I think this presentation is very convincing. We are really moving towards a new era in the management of non-small cell lung cancer with this new class of agents and with this new molecular subgroup with fusion genes involving NTRK. Thank you very much for this first clinical case. And now we are moving towards our third presentation on